Thank you, Laurent. Shalom. Good morning to everybody. It's a great pleasure for me to be here, and I would like to thank again very much Laurence for her very kind invitation, for her enthusiasm, her optimism and kindness as every year. This year we've decided to talk about an hot topic. It's about the new screening modalities based on cell-free DNA in the maternal blood. So I'm really sorry for those of you who are radiologists and maybe who are not very much aware of these new technologies. I think it's really important for you to know what are the advantages of these new technologies, as well as their pitfalls and limitations, because it can have a huge impact on your examination. So we'll talk about cell-free DNA in the maternal blood in the first trimester and how it can impact on your first trimester examination during pregnancy. So a very short disclosure, nothing special to declare. And I just want to remind to those of you practicing either in France or in other countries that there are recommendations, guidelines about how to perform a first trimester examination. This is the report that we have in France telling us what we should do in the first trimester of pregnancy, and everywhere in the world, including in Israel, you have recommendations about what should be done and what should be seen during the first trimester of pregnancy. Basically, the three main images that are performed during the first trimester are these three that you can see here. One is chromosomal length. It's the measurement of the maximum length of the embryo, and it tells you about the gestational age, and it's a very important measurement. This one is the biparietal diameter. It allows you to look at the fetal brain. And the third measurement is related to screening of chromosomal abnormalities. It's what is called nuchal translucency measurement. This is just to show you what is a first trimester normal ultrasound examination. You are here in axial view of the embryo starting from the head. This is a short video from the Fetal Medicine Foundation. You've seen the two ventricles, you've seen the midline. You can now see the orbits of the fetus. Now you see the upper lip. It's quite difficult to see, but you are going down through the embryo in an axial view. Now you can see the four-chamber view as early as in the first trimester, as well as the fetal lungs. You keep going down, keep moving down. Now you can see the abdominal circumference with the stomach. Keep moving down. You come to the umbilical cord insertion on the abdomen of the fetus. Now you can see the fetal bladder and the legs. And if you do the same kind of sweep on a sagittal view, you can see very well one arm, one hand, and then you move to the sagittal plane. You can see the nuchal translucency here, the other hand on the other side, and again the bladder, the legs. So you can see that very briefly, when the technical conditions are quite good, you can do a really good anatomical scan of the embryo as early as in the first trimester. But another important purpose of the first trimester examination during pregnancy is to screen for chromosomal abnormality. And again, the modality to screen for trisomy 21 are well standardized all over the world. And this is basically how it has been organized in France for the past 10 years. So very briefly, because I think it has been quite the same in Israel for a while, probably it's now changing, of course. What you do is what we used to call a first trimester combined screening. It means that you are going to assess the risk of a mother to carry a Down syndrome fetuses by looking at her maternal age, by looking at the nuchal translucency of the baby, and by looking at the maternal serum markers. And based on these three elements, you're going to assess what is the risk of the woman to carry a baby affected by Down syndrome. If the risk is high, which is above 1 out of 250, then the screening is said to be positive, and you have to do something else in order to confirm that everything is okay, because of course in most of cases everything is normal. The karyotype that you will be performing by doing an amniocentesis or a chorionic villus sampling will be normal. And in some case, it can find a trisomy 21. When the risk after the first trimester combined screening based again on age, nuchal translucency and serum markers is low, then usually you do an ultrasound follow-up until birth. So this is the way it was organized for many years. The overall sensitivity for Down syndrome of such a screening strategy is around 90%. And the main limitations of this strategy is that because you are doing an invasive procedure, either amniocentesis or chorionic villus sampling, you are exposing the mother to a risk of fetal loss and miscarriage that has been estimated for many years of around 0.5 to 1%. So this is the main drawback of this strategy. So again, this first trimester combined screening is based on maternal age because we know that the older the mother, the higher the risk of trisomy 21. Nuchal translucency measurement, and you know everything about this nuchal translucency measurement. It has to be performed with good quality criteria, which means a strict sagittal view. And then maternal serum markers, HCG and PAP-A. And based on these three elements of the first trimester combined screening, age, nuchal translucency, and serum markers, you are able to detect 90% of Down syndrome for a 5% false positive rate. It means that you are going to worry 5% of women to detect 90% of cases. And this has been the standard of care for many years. But there was a revolution a few years ago, and this revolution is the discovery of cell-free fetal DNA circulating in the maternal blood. Every woman, every one of us, has cell-free DNA circulating in the blood. But if you are carrying a baby as early as 8 weeks of gestation, you will carry some cell-free DNA particles originating from the placenta and the baby. And because researchers have been able to analyze this cell-free DNA, we've been able to realize a new way to screen for Down syndrome. So very basically, how does this work? Fetal DNA circulates in the maternal blood and it's mixed with the fragments of DNA originating from the mother. With the new technologies, we are now able to massively amplify and sequence these DNA fragments, and we are able to establish the chromosomal origins of these DNA fragments and count them, which means that you are able to count what is the quantity of DNA fragments originating from chromosome 1, from chromosome 10, from chromosome 21, etc., etc. Which means that in the case of a fetal trisomy 21, you will have some excess of DNA fragments originating from the chromosome 21, which comes from the fetus, which is affected by Down syndrome. So this is an illustration. There will be a very small excess of chromosome 21 fragments that you are able to detect in the maternal blood, and you don't even have to differentiate between maternal DNA and fetal DNA. The overall quantity is in excess in a case of trisomy 21. Why? It's because the DNA originating from the fetus will represent around 10% of the overall cell-free DNA circulating in the mother. So this is an illustration. Imagine that you are analyzing 100 sequences originating from chromosome 21. In a normal case with a fetal fraction of 10%, you will find 10 sequencing originating from the fetus, but again, you don't have to differentiate between those fragments coming from the fetus and those coming from the mother. But in a normal situation, you would have 10 fragments originating from the fetus and 90 originating from the mother. But in a case of trisomy 21, the fetus doesn't have 2 chromosome 21, he has 3, which means that in the same situation, instead of having 10 sequences coming from the fetus, you will have 15 of them, and still the 90 coming from the mother, which means that the test is going to detect not 100 sequences from chromosome 21, but 105. and the test will be positive. And you can see that it's not at all a fetal karyotype. It's only the count of cell-free DNA fragments circulating in the mother. So this test has a huge performance. The overall sensitivity is a little bit more than 90%, and the specificity is also a little bit more than 99%. So it's a very, very good test. And because of this new technique available for us, it has been necessary to reassess what is the best screening strategy and how to incorporate this new test in our strategy and to reaffirm what is the exact place of ultrasound in the first trimester with this new modality. And this is what I'm going to talk about right now. The first very important thing is to respect patient's autonomy, which means that we have to inform the woman about this new test, about its performance and its limitation. In France, this has been the first step of the process of incorporating this new test to define exactly what is the performance of this test and to give information to the woman about that. The second important thing is that although there is this new test that is available for screening for trisomy 21, this will only screen for trisomy 21, and this means that all women should still be offered a first trimester ultrasound examination. And this is really important, and ISWOG, which is the International Society of Ultrasound in Obstetrics and Gynecology, has reaffirmed the very important role of first trimester ultrasound examination. And what is the main reason for this important role? Is that again, this blood test is only testing for trisomy 21, whereas ultrasound examination is looking for many more abnormalities than only trisomy 21. And you've seen during the short video in the beginning of this talk how many things, how many anatomical assessments you can perform with the first trimester ultrasound examination. So now it can happen in some cases that the woman, when she comes for the first trimester ultrasound examination, she already had a cell-free DNA test for trisomy 21. I think it should not be the case, because I think it's better to first confirm that the first trimester ultrasound examination is normal before performing this test. But in some cases, she will come with the result of this test. And in this case, you should still perform a first trimester ultrasound examination. You should still perform the nuchal translucency measurement, but probably it's not useful to perform a risk assessment. If the woman has not yet had a cell-free DNA test, then now it's really important to inform her about the possibility of performing this new test and to inform her again about the performance and limitations of this test. What has been recommended by ISWOG is to perform the normal first trimester ultrasound examination, is to perform the normal first trimester combined screening, as we've seen, based on maternal age, nuchal translucency, and maternal serum markers. And once you have the results of this test, of this first trimester combined screening, to decide with the mother what is the best strategy and what she wants. And the answer can be different depending on your public health policy, on your health priorities, etc. There are mainly two possibilities: either to keep using two groups, one that will be defined as high-risk group, as we used to do before, and one that is low risk. And the other possibility is to do three groups, and this is what we decide to do in France. So again, you do the first trimester combined screening, and based on this first trimester combined screening, you will define a very high-risk group to whom we should keep offering an invasive procedure in order to rule out chromosomal abnormalities with a 100% sensitivity, a low-risk group to whom you would only offer an ultrasound follow-up, and an intermediate risk group to whom we suggest to offer cell-free DNA test. So these are the thresholds that have been chosen in France. So we define the high-risk group as the woman with a risk above 1 out of 50. The low-risk group are the women with a risk below 1 out of 1,000. And the intermediate risk group is the group of women with a risk in between. But again, ISWOG has recommended that the woman should be clearly informed about what this cell-free DNA is able to see and what it's not able to see. Again, it's a super screening test. It's not a diagnostic test, it's not a karyotype, which means that you have to balance the possibility of this test with the possibility of an invasive procedure and the possibility of a karyotype to rule out many more abnormalities. One of the biggest advantage of this test, this cell-free DNA test, that has been put forward by all the private providers in order to sell as many tests as possible, is its ability to avoid invasive procedures and therefore to avoid miscarriages in women. So this should be the main advantage of this test. It does not see all chromosomal abnormalities, but it should avoid procedure-related pregnancy losses. But this has been very controversial over the past years because this risk of miscarriages following an invasive procedure, which has been evaluated as 1% of cases for many years, is now challenged by many studies which said that eventually the risk of miscarriages after an invasive procedure to establish the fetal karyotype is almost zero. Look at the conclusion of this test, of this article. Neither CVS nor amniocentesis was associated with increased risk of miscarriage. And this is also the result of a randomized clinical trial that we've been performing in France, in which we've been involving more than 2,000 women. We have randomized high-risk women in between cell-free DNA and fetal karyotype based on amniocentesis or chorionic villus sampling. And very briefly, what we've seen was that the number of miscarriages or pregnancy losses in the two groups was exactly the same. So therefore, this pretended advantage of this new test does not still. And the other problem is that, again, this cell-free DNA test will only rule out trisomy 21, not other chromosomal abnormalities. It could rule out trisomy 18 or 13, but not the subtotal chromosomal abnormalities. And when you know that on the other side, by doing an invasive procedure and by establishing a karyotype, you could also perform a microarray, which could see many more abnormalities, then this is the new balance between the two tests. By using chromosomal microarray, you can see many, many more abnormalities than by using a simple cell-free DNA test. And if safety is no longer an issue, because if we say that invasive procedures do not carry an excess rate of miscarriage, then it really changes the prenatal counseling that we should offer to the woman. And again, in our randomized clinical trial, this is what we saw. In the group which had an invasive test, we detected many more chromosomal abnormalities than in the group who only had the cell-free DNA test. So again, this is really important to adapt our prenatal counseling to this new concept of invasive procedures not carrying a real excess rate of miscarriages and pregnancy-related losses, and of microarray having the potential to detect many, many more abnormalities. So this was the first screening strategy that was possible, offering a first trimester combined screening and then based on this first risk assessment to decide either to perform an invasive, a cell-free DNA test, or nothing. A second implementation strategy that could be possible would be to offer cell-free DNA to everybody. Of course, this would be the normal advance of screening for trisomy 21. You can see what was the screening modalities for the past 30 years. And of course, it seems logical now to offer cell-free DNA tests to everybody. But it's not as simple, because this cell-free DNA test still carries some false positive case and also some failure cases. And there is a real problem to know how to manage all these failure cases and false positive cases if we were to offer cell-free DNA tests to the entire population. And there is also the problem of the cost, because at the moment these tests are still quite expensive. It's around $400. And so for the moment, such a strategy does not seem reasonable. But for sure, as the prices are going down, it's going to be more and more often the strategy that is going to be applied. And another potential of offering cell-free DNA to everybody, another risk, is not to respect patients' autonomy and to prescribe cell-free DNA to everybody as we are prescribing blood group or blood count, without informing the mother about what we are doing. And the other risk is that this may lead to a reduction in the quality of the ultrasound examination, because people will think that they are covered by this cell-free DNA test, which will detect trisomy 21 case, and that they could overlook it by ultrasound, but the problem is that they will overlook many more other abnormalities. So this is just to illustrate that cell-free DNA only works with a good ultrasound examination. So now, very briefly, some other concepts that we've wanted to underline and to emphasize in the ISWOG guidelines. It's that, again, because of the new performance of cytogenetic techniques and because of the new performance of microarray, and because of the recent reduction in the reported risk of invasive procedures, it's really a discussion that we should have with mother, because mother, when they are coming for prenatal diagnosis, what they are interested in knowing is not about trisomy 21 only, it's about the risk of handicap and of developmental delay. And if they really want to have the best information, then they should have a microarray and an invasive, because it can see many more things. The other important concept is that cell-free DNA test is not a diagnostic test, it's only a super screening test that will greatly modify the risk that you've been assessing during the first trimester, which means that if it's positive, it increases massively the risk that the woman is carrying a baby with Down syndrome. And if it's negative, it reduces massively this risk. But it's not normal or abnormal. And therefore, there are some risks of false negative, and you have to know that. And I've seen in the internet some cases here in Israel. And it means that you have to assess the new risk, even with the result of a cell-free DNA, based on the previously assessed risk, based on the a priori risk. And if the risk was very high, even with a negative test, then the risk is still quite high. And if the risk was very low, even with a positive test, then the risk is still quite low. And the second important thing that you have to assess to interpret correctly this new cell-free DNA test is the fetal fraction. The fetal fraction, again, is the quantity of DNA originating from the fetus as compared to the entire quantity of DNA. And the higher the quantity of fetal DNA, the better the test performs. And if the fetal fraction is low, then the test is not performing very well, and you have to assess this fetal fraction when you are interpreting this test. Another important statement is that whenever you find an abnormality at the ultrasound examination, then in this case you should still perform a normal karyotype or a microarray. You should not rely on a simple cell-free DNA test. If there is a failure in the cell-free DNA test, you have to know that this failure occurs in 1 to 2% of cases, I would say now, and when the test failed, it increases the risk that the baby is carrying an abnormality, and especially a trisomy 21, because we know now that there is a correlation between carrying a trisomy 21 and having a low fetal fraction, and therefore a higher risk of failure for the test. Which means that if you get a result that is a failure, the risk has increased, and you should counsel the woman according to this increased risk. Another important statement is that, again, this cell-free DNA test is only a super screening tool. It's not a diagnostic test, which means that if you have an abnormal result, it has to be confirmed with an invasive before changing the pregnancy management. Indeed, there are false negative cases, but there are also false positive cases, so you should not terminate any pregnancy before having confirmed the diagnosis based on an invasive. We should also assess what is the performance of these new tests in twins, and it has not been really investigated so far. We should also assess what are the differences between the different providers, because it's possible that the performance of these tests are not the same with all the providers. You have also to know that the providers is now offering more and more screening possibility based on this test, and you have to know that by having multiple tests, you will increase the risk of false positive results. And last but not least, that we still need massive prospective publicly funded studies in order to assess what is the best place for this new screening strategy. So as a conclusion, I would recommend you to read this consensus statement about the impact of cell-free DNA in ultrasound practice. I would like to remind you what is probably at the moment the best screening strategy. It's again to rely on the first trimester combined screening, and then to define 3 groups of risk: high risk, low risk, and intermediate risk, to whom you will offer this new cell-free DNA test. And then, depending on what are your resources, how many money you have, you can adjust these thresholds to fit the best to your public health priorities. And again, I would like to remind you, as a very last slide and as take-home messages, what are the new rules for pretest counseling because of the new test. The most important thing is that we have to keep parental autonomy. We should inform the parents about these new modalities, their potential and their limitations. The first trimester ultrasound examination, and for all of us practicing fetal imaging, it's a good thing. The first trimester ultrasound examination should remain unchanged. We should also inform our patients about the new risk, the updated risk of invasive procedures that is probably close to 0, and this is very important. And therefore, we should inform them about the possibility to offer a comprehensive genetic screening based on new strategies such as MICROARRAY. Thank you very much, and I'm open for discussion.